question here, the nurse has reviewing with the pre-operative client the procedure for administration of enema. Which statement by the client would indicate the nurse to need for further instruction? So out of 4, which one my patient telling something wrong, I need to correct them? Or what I'm going to teach them when patient are remodeling it, maybe there's something doing wrong, I have to make correct. So the patient is a pre-operative patient. Maybe patient need to the bowel surgery tomorrow morning, and tonight we need to clear the bowel and we give them some enema. If preoperative, patients sometimes can do them by themselves. So out of 4, what is the wrong information here? The enema will be given while I'm sitting on a toilet. But my friend, never ever enema give or administer while they are in toilet. Never ever. Because of safety, easy way to explain. Number 2, I should try and hold the fluid as long as possible after it is inserted. So I will try and hold. So basically, if do not try, it will become out. So it is nothing wrong. I know that there will be some cramping after enema admission. Yes, it is the known bit adverse effect. So it's little bit enema causes the cramping. And number 2, because the gravity it should be came out, so it is good to hold. I should tell the nurse if cramping occur during the installation of the fluid. If cramping occurred during the installation of the fluid, here they said. So I said, if we see any complication related to the colon or too much cramping, we have to inform the healthcare provider, or we can help to inform the duty RN or LPN. So the out of 4, at least number 1, we should that it is not a position, it is not for the good for our safety of the patient. So we need to tell our patient, don't do this because of the safety. What is the rare rationale here? They said the enema is never administered while on a toilet because of safety. The enema is administered while the client is in left side position or Sims position. Position with the right knee flex. So the left side lying, other language is called Sims position. And the right knee supposed to be flexed. And this allow enema solution to flow the downward by gravity along the natural curve of the sigmoid colon and rectum. It is important for the client to retain the fluid for as long as possible, since this will promote the peristalsis and defecation. If the client complains of fullness or pain, the flow is stopped for 30 seconds and restart at a slower rate. So this is the information we learn, right? So during the process, if patient complain of pain or fullness, it is good to stop for a while and then again start, but slow rate. So what next? Question here, the client stated to the home health nurse that she has not had a bowel movement since coming home from hospital. After hospital, what happened? Surgical operation. They said after surgery 4 days ago. So patient had a surgery 4 days ago, stay in hospital, came at home and complained to the home health nurse. The nurse instructed the client to follow which diet at that time. So bowel movement, no bowel movement means patient have an absolute constipation. So after the surgery, when you work in the hospital, you will learn after the surgery, we will try to ambulating the patient. When patient is ambulating or even there's some factor related to the bowel movement, some psychological factor, physical activity who do less, they have a chance to develop constipation or bowel doesn't move at all. Or sometime inadequate food that containing a good amount of fiber also causes the constipation, even some medication, right? So now out of 4, the examiner make it easy for us. Which diet? So this is the, I said there are so many medication can cause constipation. But here only talking about the food diet. High fiber diet. Which diet should be included? The nurse should instruct the client. High fiber diet, definitely it is. Full liquid diet. Liquid is good. Intake fluid is good, but patient does not need the full liquid diet. Or low fiber diet, no, never. Or low sodium diet. If your patient have a heart problem, you tell them to low sodium diet. If your patient has some diverticulitis active phase, you give them low diet, right? But my patient has a constipation, definitely high fiber food is most appropriate for them. What is their rationale? Constipation is the probable cause of the client lack of bowel movement. Constipation is difficult or infrequent passages of stool which are hard and dry. Constipation has numerous causative factors like some psychological or psychogenic, lack of physical activity, inadequate intake of food and fiber, and also some medication can cause. High fiber diet often is indicated for constipation because it will promote the bulk and encourage the intestinal peristalsis movement. Let me talk about little bit about the full liquid diet. Full liquid diet will aid if the fluid but no bulk to help relieve the constipation. Like your patient has a difficulty of intake the food, then you can give them full liquid diet. It is not related absolutely with the constipation. Our best choice, number 1, high fiber diet. So the nurse is preparing to administer the enema to a pre-operative client. In which position should the nurse place the client to administer enema? Click the image to indicate your answer. So there are picture 1, it is called prone position. Patient lie down on their abdomen. And picture number 2, it is patient lie on their back position, and also the bend the knee joint. And number 4 is simply lie down on bed or back, patient lie on their back and facing towards the road. The picture number 2 it is called Sims position or left lateral position. The right knee is flexed, and this is the position we prefer for enema because of gravity and curvature of the colon. This, if you put the enema in this position, the enema should be left there for a long time and retention inside the colon and also the terminal part of the ileum, right, or gut. So this is the reason we choose the Sims positioning for enema. What is their rationale? Administer an enema, the nurse assists the client into left side position or called Sims positioning. And with the right knee is flexed. This position allows the enema solution to flow downward by gravity along the natural curve of the sigmoid colon and rectum, therefore improving the retention of solution inside the rectum. What next? So before enema administration, the nurse position the client in left lateral positioning. What are the rationale for using this position? Easy question. So we know that the Sims position or left lateral position and right knee is flexed, the best position for enema, putting the enema. Why we choose this position? What are the rationale? It is more comfortable. Answer 2, it facilitates the passage of stool. Number 3, it prevents a vasovagal response from occurring. It facilitated the instillation of the enema solution into the colon. Because of the curvature or position of the colon, the left lateral is the best because of the gravity, and positioning helps to retention of the enema inside the colon for a longer time. This is the reason we choose the left lateral position. One is gravity, second is structure of the colon, and also allowed to more area to open the anus. This is the reason we chose number 4, right? I want to give a clue, my friend. In NCLEX board exam, sometime I said, example, I do not know which one is the answer. In that scenario, you have to try to see which is the longest Which is sentence or answer content more information? Which sentence or answer out of 4 more than 1 or 2 sentence connected by conjunction like and or or rephrase the sentence, or out of 4 sometimes 3 is look like same but 1 is look like different. The NCLEX choose that answer too. So the rationale here, the sigmoid and descending colon are located into the left side. Therefore, the left lateral position use the gravity for facilitate the flow of solution into the sigmoid and descending colon. Acute flexion of the right leg allow for adequate exposure of anus as well. So this is the reason we chose number 4. What is facilitate the installation of enema into the colon. What next? Question here, the client has a prescription for administration and enema. After prepare the equipment and solution, the nurse should assist the client into which positioning? Easy. So left side or left side lateral or sim. Right side, left side lying with head of the bed elevated. Right side, definitely right. Number 2 and 4 never ever the answer. And number 4 is not answer. Number 3 is not answer because they said left side lying, but we know left side lateraling, which is called Sims position. Definitely it is the answer. And the left side lateral or Sim position we choose because the colon also in the left side, and they help the stay the enema in the longer time because of curvature of the colon, direction of the colon, and also the gravity, right? So what is their rationale? When administering the enema, the client is placed in a left side same position so that the enema solution can follow by gravity in natural direction of the colon. The client is lie on his or her side with the body turned approximately 45 degrees. So this is the answer we chose. What next? So the nurse is inserting indwelling catheter, urinary catheter. As the catheter is inserted into the urethra, urine begins to flow into the tubing. What should the nurse do next? So we must know what are the step-by-step process to indwelling catheter. When you insert the catheter, you have to follow some steps. Here they said, immediately twist the catheter, then slow inflate the balloon. So you never do the twisting the catheter, right? It is not professional way to deal with the catheter, but you must need to inflate the balloon. Insert the catheter 2.5 to 5 centimeter further and then inflate the balloon. So you have to insert the catheter adequately and then inflate the balloon. It is a good choice. What about number 3 and 4? Insert the catheter until resist is met and then infect the balloon. So because of your enough anatomical knowledge, your skill, you should know what should be the maximum length we need to insert. We do not wait to resist. If we wait until to resist, chance to injury your patient urinary system, because body is very sensitive. So it is not an answer until wait to resist. Withdraw the catheter approximately 1 inch and then no, we do not withdraw because the urine is begin to flow into the tubing. So we answer to 2 because we need to adequately insert and balloon inflect. So it will not come out, right? So what is their rationale? The balloon is behind the opening of the catheter tip. The catheter is inserted 7 to 9 inches after urine begins to flow. So this is the point we learn here. So 7 to 9 inches need to insert and after urine begins to flow, providing sufficient space to inflate the balloon. When you inflate the balloon, the catheter will not come out because of gravity, but when time will come to remove the catheter, we have to deflect the balloon first, then slowly remove the catheter from urethra. Otherwise, have a chance of injury or strict chance to develop the stricter urethra. A common question come in NCLEX board. During insert the catheter, we have to strictly maintain the precursor to prevent the infection. Thoroughly washing the hand, wear the gloves, and maintain all precaution to prevent infection. Infection prevents the most priorities because infection can cause UTI, urinary tract infection. Urethra into the balloon. So inflate the balloon into the urethra could produce the trauma. The catheter should be neither withdraw or nor advanced until resist, right? Because if you wait for the resist, chance to injury. What next question? Question here, the client complained of the pain as the nurse is inflecting the balloon during insertion of a Foley's catheter. The nurse should take which immediate action? So when you work in the floor, maybe you patient need to insert the Foley's catheter and you doing it. But when you inflecting the balloon, patient complain of pain. So my question here, the client complaining pain as the nurse is inflecting balloon, what we should do next? What are the best option? First one, withdraw the catheter slightly and re-inflate the balloon. So you already insert the catheter. It is not a good choice to withdraw the catheter. Number 2, remove the catheter and reinsert. No, the chance to again injury if injury is there, right? Because the organ is too soft. If you handling too much time, the more chance to injury, and this injury is bad because patient chance to develop UTI or stricture urethra. Number 3, finish the inflecting balloon. The discomfort is normal and temporary. Finish the inflecting. No, if you patient complaining the pain, you can't continue the procedure. If damage there, damage will be more. Especially the position of balloon is if not accurate. So what we could do, aspirate the fluid, advance the catheter further. Maybe it means balloon is not a good positioning, so pain start. But when you reposition, go next further little bit, maybe balloon will be positioned, will be okay, and pain will subside. So aspirate the fluid, advance the catheter further, and then re-inflate the balloon. Because as I told you, withdraw the catheter, remove the catheter is not a good choice. Patient chance to more injury. And also patient has a complaint already. We do not continue same thing. Maybe the balloon position need to repositioning, not appropriate position. So it is better to push little bit further, then inflate the balloon. What is the rationale? If balloon is malpositioned, the balloon inflect could cause the trauma and pain. If this occur, the fluid should be aspirated and catheter insertion a little further to move the balloon past of the neck of the urethra into the bladder. The catheter should not be withdrawn slightly because this will worsen the problem. There is no need to remove the catheter and reinsert a smaller one. The balloon should not continue to inflected because the pain is not normal and will not go away. What next? Question here, the nurse is caring for a client with a chronic kidney disease. The nurse knows that beside maintaining the urinary elimination, the kidney also involved in what body process? Easy way, what are the function of the kidney? What are the role out of the kidney in our body? Select all. So in this question, one function is kidney already mentioning, maintaining the urine elimination. So kidney formation the urine, also expel out the urine. We call urine elimination. What are the other function of the kidney? Kidney helps to regulate blood pressure. Yes, because kidney maintain the blood fluid. Also, kidney has an important role by aldosterone, retention of water and electrolyte. Encouraging immunosuppression, never ever, right? Immunosuppressed, no, it's not a good choice. Stimulate the liver to secrete enzyme, never. Assist the regulate acid-base balance, important. Kidney is one of the organ participate regulation of the acid-base balance. Convert the vitamin D to active form. Yes, vitamin D formation in the skin under the sunlight, but vitamin D be activated when they are inside the kidney and produce erythropoietin for red blood cell synthesis. So erythropoietin is one important hormone that can helps to red blood cell get maturity. Important. So answer is 1, 4, 5, and 6. What is our rationale? Besides maintaining urinary elimination, the kidney are also involved in helping to regulate blood pressure, assist to regulating acid-base balance, converting the vitamin D to an active form, also promote erythropoietin for red blood cell synthesis. Kidney do not encouraging immunosuppression and do not stimulate liver to secrete the enzyme. What next? Question here, the nurse is caring for a one-day post-operative client who is complain of urinary retention. The keyword is here, the keyword here, one day post-operative. And patient complain of urinary retention. What are some of initial assessment technique or intervention are the nurse should employ and select all apply? So your patient just came after surgery, one day post-operative, and complain the urinary retention. So what is your initial assessment? And we have to select more than one answer here. So palpation. So if my patient has a urinary retention, palpation, definitely I will do it. It is the part of assessment. Inspection, yes, I will see what are the distension because of retention of urine. I will do it. I will do for percussion to see any kind of content or not. Is it fluid or anything else? We have to evaluate it. Auscultation, it is not a lungs that I will put the stethoscope and auscultate it. It is not a choice. Bladder scanner, yep, it is also, we need to exclude. Insertion of Foley's catheter. So insertion of Foley's catheter are not intervention after post-operative urinary problem, and doctor can decide insert a Foley's catheter or not. We are not directly able to do this. So our answer is here 1, number 2, number 3, and bladder scanner, right? So let me check their rationale. What they said: control of urination may return immediately after surgery or may not return for hours after general or regional anesthesia, because anesthesia has an effect over the urinary bladder muscle, chance to retention urine. The effect of preoperative medication is also one of the causes, especially atropine. Anesthetic agents or manipulation during surgery can cause urine retention. Assessment may include to perform after lower abdominal surgery and assess for urinary retention by inspect, by palpate, and auscultation of the lower abdomen for bladder distension or by the use of a bladder scanner. Auscultation and insertion of the Foley's catheter, not intervention for initial post-operative urinary problem. And as I told you, auscultation does not rule out anything in case of urinary bladder. And also Foley's catheter will prescribed by the doctor. As a RN, we are not the person to do this.